Thank you so much for the introduction. Changing gears here, type 1 diabetes to monogenic diabetes. But before that, I'd like to thank the organizers for calling me here, Dr. Parag Rana, Dr. Akash Singh, Dr. Jethwani. So I'll be talking about this topic, which we clinicians don't look into much often, because any and everyone which comes to us, we believe has either a type 1 or a type 2 or a GDM, but this is oft ignored. So therefore, this would be my scheme of action as I talk about. So monogenic diabetes are inherited disorders. They are autosomal dominant, and there is glycemic dysregulation. There may also be hypoglycemia, not only hyperglycemia. So now we have 14 different types of MODY which have been described. So what are the ones? Number 1, neonatal. Number 2 is MODY. Number 3 are diabetes which have extra pancreatic manifestations, and of course the monogenic insulin resistance syndromes. So this is again a chart which shows that obviously type 1 and type 2 are polygenic. Rest of course are either chromosomal linked or monogenic. So moving on, this diabetes is diagnosed generally within the 6 months of life, the initial 6 months, sometime maybe up to 1 year, frequency of about 1 in a lakh, and as the age advances, possibly 1 in 2.5 lakhs of patients. May be transient, may be permanent, but more than 50% generally are there to stay. So transient, they may resolve in 6 months. The problem is with the potassium ATP channel. That is the most common cause, and therefore sulfonylureas have shown improvement in these patients. So these patients may not require insulin for all you know. And also, this is a bearing that if diagnosed within the first 6 months, testing for genetics is paramount in these patients. The different types, busy slide, won't go into all this, but as I said, may be temporary, may be permanent, but if it's permanent, eventually they will require insulin. MODY, the oft discussed, so described in 1974 by Fadjans and Tattersall. Autosomal dominant inheritance is what we are talking about, and of course there's a problem with the beta cell activity. Ketosis does not happen. Hyperglycemia may be mild to severe, but the commonest, which is MODY type 2, has a mild hyperglycemia. So the characteristics: number 1, young child, or young male maybe, young female, you do antibodies, they are negative. Number 2, ketosis is very, very rare. When we talk about type 1 diabetes, there's something called the honeymoon phase. Here, that so-called honeymoon phase lasts longer, maybe 3 to 5 years. C-peptide can be found, so it is not type 1. And as C-peptide are present, which obviously are the surrogate marker for insulin release, these patients may do well on either low-dose insulin or even sulfonylureas. Typically, 3 generations are involved. Typically, age of 25 or below has been described, but there is data to show that people may present as late as age 35. So MODY, typically the type 2, the glucose cannot make its way to the beta cell through blood transporter type 2, and it does, but the beta cells also may not be responsive, so the release of insulin is suboptimal. So this has 2 meanings. Number 1, that sugars may be slightly high, and number 2, you might not need exogenous insulin for all you know. So these are the various types of MODY. The commonest one being MODY 2, but the commonest one requiring treatment is HNF4 alpha. So the glucokinase MODY or the MODY type 2, mutations in the long arm of chromosome 7. Beta cells, as I said, do not detect glucose adequately, and therefore these people have mild fasting hyperglycemia, but if you do an OGTT, they do not reach the threshold of 200. So possibly diagnosed on the fasting basis of more than 126, and obviously you have preserved C-peptide, and that is why levels don't reach 200. HNF1A MODY, so mutations in the transcription factor, and therefore because of this the beta cell function is hampered. There's also some thought that the SGLT2 activity may be aggressive or overactive in these patients, and this, as I said, is the MODY which requires treatment most often. The disease is progressive, requirement of insulin may be there, DKA is not unknown but generally does not happen there, liver adenomas do happen. So HNF4 alpha, now this is type 1 MODY, and there is progressive loss of beta cell function. These patients are more prone to micro and macrovascular complications, and as I speak, all of this will have a bearing in the future treatment of these patients. They respond to sulfonylureas and they require insulin because it's a progressive disease. So initial response is there to sulfonylureas. If these people conceive, it goes without saying that you should stop the sulfonylureas and go to insulin. HNF1 beta, so in this gene, there is a problem in secretion as well as the development of the pancreas. It is also called the RCAD, renal cysts and diabetes syndrome. Deletions in the short arm of chromosome 17 happens in the mid-20s, maybe autism, maybe issues with intellectualism, and they do not respond to sulfonylureas, and therefore insulin has to be used. So how do you work up? Well, you get a young child. I'll cut this short. You get a young child. What do? You first look at the urine ketones, the HbA1c. If it is reasonable, maybe 8 to 9, only then perform the C-peptide. HbA1c more than 10, do a C-peptide. It will be low. It will puzzle all of us. So if the patient has high HbA1c, maybe put him on insulin, and once the levels are fine, stop insulin for 24 hours and then do a C-peptide, or at least overnight stopping should be there. Otherwise, it will all be low and confuse all of us. So DK is there, antibodies are there, possibly type 1 diabetes. Age less than 6 months, as I said, consider neonatal diabetes. Then if the sugars are high but somewhat preserved, C-peptide, obese child, acanthosis, skin tax, family history, consider type 2 diabetes. And let me tell you that when we were students, 15-year-old child, you say type 2 diabetes, you would be failed in the examination. But now with the junk food available, the fast food available, type 2 diabetes is happening increasingly in young children. The biomarkers, I'll jump, but there's something called the urinary C-peptide creatinine ratio. There, 0.6 nanomoles per millimole or more than that would signify a type 2 or a MODY. Less than that, possibly type 1 diabetes. So these are the subtypes: HNF4 alpha, sulfonylureas. The glucokinase might not require treatment for all you know. The NF1 alpha, sulfonylureas, HNF1 beta, insulin, and this KCNJ, which is MODY 13 sulfonylurea, and ABCD 12, again sulfonylureas. So this is the scheme of how you manage, except for the glucokinase, all require either sulfonylurea or a diet control. Only MODY 2 can be managed on diet and exercise. So the other syndromes, well, something called the Wolfram syndrome, the DID mode, which is diabetes insipidus of the central variety, diabetes mellitus, optic atrophy, And deafness, again, sensorineural. So it is non-autoimmune, presents earlier than 6 years usually, and as I said, optic atrophy is there. Then of course, RCAD, MODI 5, renal cysts and dysplasia, defects in the system of genital and urinary, so possibly posterior urethral valve may be present, which may actually cause hydronephrosis and renal failure early on. And of course, sometimes abnormal LFTs. Then mitochondrial diabetes, usually insidious, but may present with DKA in certain subsets. These are the people in whom the reserve of beta cell is lower, and also high glucagon levels may be found in these patients. A word or two about insulin resistance. Now, insulin levels are ordered right, left and center in anyone who is overweight. The diagnosis of insulin resistance is written on the body. You look at the belly, you look at the double chin, you look at the acanthosis, look at the skin tags, finished. I mean, why do you need to document all these things? But nonetheless, in these patients, there is negligence. So, defects may either be signaling or in the adipose tissue, and mind you, adipose tissue is the largest endocrine organ of our body. And of course, syndromes like the Prader-Willi, even Down syndrome, even Klinefelter syndrome, they all have insulin resistance. So one must understand that for diabetes to happen, insulin resistance might not be sufficient. There has to be an insulin secretion defect. It may either be absolute, as in type 1 diabetes, or may be relative, as in type 2 diabetes or the MODI. So what about the current research and unmet needs? First of all, we must understand that for monogenic diabetes, treatment is available and they sometimes respond much better to sulfonylurea rather than insulin. A patient may discontinue insulin and go to oral medication. I am in no way saying here that pricks are harmful. All I am saying is that initially sulfonylureas may treat it better. It might leave a good legacy of glycemic control, and therefore the risk of complications might be lower in these patients if initially they are given sulfonylureas. Obviously, if you are not on insulin, then the aggressive monitoring might not be required 4 times, 5 times a day. So that obviously obviates the cost of the glucometer, the strips, the lancets, and also it may make life more convenient for the patient. So the current research which is going on, the PREDICT, the Precision Diabetic Consortium, so advancing monogenic diabetes research and practice in consortium. So they are making a dietary, consensus dictionary that will be used to address the critical gaps. The RADIANT, the Rare and Atypical Diabetes Network, and the aim is to improve identification, diagnosis of the condition, and precision medicine. This slide, I'll just be talking about the MODI calculator developed in Exeter. This calculator actually involves the family history, the age, the BMI, the C-peptide levels, and if the total is more than 60%, then they say that you should, the testing for genes should be done for diagnosis or exclusion of MODI as the case may be, and therefore this may help in decision making. Now something called precision medicine, there is something called the investigative parsimony, and there is something called a therapeutic parsimony. Investigative would mean that you do investigations which are of paramount importance, without which things will not move forward. But if you do that, you actually save lots of patient money. The therapeutic parsimony would mean that every youngster put him on insulin. No, that's not the case. So that would again, as I said and I repeat, it will make the life convenient and put the patient off insulin, give him a good glycemic memory and delay the complications. So MODI 13 successful with sulfonylureas, improved outcomes without insulin. Type 2, they might not require treatment for all you know. Diet and exercise may be sufficient. HNF1 beta, variable expression, and they may be acute and long-term outcomes. Now, precision diagnostics and prognostics. So, diagnostics, again, as I said, anyone below 6 months, consider neonatal. There's gestational diabetes and early onset. So you do the panel, the genetic panel, and conclude the diagnosis. Once diagnosis is made, you have the precision treatment. For example, 13 response to sulfonylureas, glucokinase, no treatment, and HNF1 alpha response to low dose sulfonylurea, particularly to glibenclamide. Precision prognostics. So as I said that in MODI 13 you need to monitor for micro and macrovascular complications. Glucokinase 2 does not cause as many, and HNF alpha you have to be very cautious about the macrosomal or the macrovascular complications of the patient. Where are the gaps? Largely underdiagnosed. We need to increase the awareness, improve pathways for diagnostic testing, researching best therapies for various types. However, more research is needed. So, to summarize my talk, MODI is a separate entity and genetics is involved. Clinical features may vary right from exocrine insufficiency to liver adenomas to renal defects to the defects in the renal system. Then of course problems not only in diagnosis but sometimes misdiagnosis, diagnosed at type 1 sometimes or type 2 sometimes. However, genetics improves clinical care and therefore genetics needs to be integrated in patients whom we suspect might not be having type 1 or type 2. Before I conclude, I take this opportunity to invite all of you to New Delhi for the IPF Medicon happening on the 5th, 6th of July. This is a purely internal medicine conference. You'll have everything right from nephrology to diabetes to endocrinology. And we have, as you can see, teamed up with the RCP Edinburgh, Nepal, Malaysia, Sri Lanka, and of course 2 universities, one in Jaipur and one in Dehradun. So I again implore upon all of you to join us for this academic feast. Thank you so much. You've been so patient and so kind.